Hello, and thank you very much for listening to Time Critical Medical Education. It's Dr. Nick Taylor again. Today I'm really excited to talk to you about this topic, should adrenaline use be arrested? And it's really a follow-on from my talk on electrical storm. So if you haven't listened or watched that one, I'd really encourage you to do that one first. Coupled with that is the talk around sudden cardiac death to make sure you've got all the background. The reality is that we have not moved very far forward in cardiac arrest management since about 1972. Back then, we had amiodarone, we had adrenaline, we had defibrillators, and we could do CPR and EAR. Now, adrenaline use came about because of some dog studies in the 1960s and 70s which said that cerebral perfusion pressure was likely to be increased in arrest situations. The problem for adrenaline, however, is that ever since these dog studies, we really haven't increased our evidence base very much at all. There's heaps of studies out there, but mostly they're observational or retrospective. There's not a huge number of RCTs. The summary of the evidence to support adrenaline's ongoing usage in all situations is quite weak. We know that you're likely to probably get more ROSC in some situations, so that's return of spontaneous circulation. We do know that there's really not much evidence at all that survival is increased, and in some studies it's worsened. I think it makes sense that survival could improve in non-shockable rhythms because what we're dealing with here is PEA, which is often volume loss. We don't expect asystole to recover very much at all. It's probably true that the timing of administration of adrenaline can influence outcome. It may be the case that giving it earlier, i.e. in the first 10 or 12 minutes, is better than giving it late, i.e. outside of 20 minutes. There's a few studies looking at this. But it's also true that giving it very early, i.e. in the first 2 minutes, may well be worse in VF and VT. And there's a recent study from BMJ which suggests that this might be the case. It might be that if you give it too late, you do worse overall, so there might be a sweet spot for the timing. A very recent study in resuscitation suggested that for pediatric in-hospital cardiac arrest, a longer dosing interval than normally suggested for adrenaline was associated with increased survival. This suggests a total dose problem for adrenaline. Other studies, it's superdose adrenaline, like 5 milligrams instead of 1 milligram, worsens survival, so high-dose adrenaline is not the answer. So as you can see, there are still loads of unanswered questions about whether adrenaline is actually good for you in cardiac arrest. Now, there might be some reasons why adrenaline is good, particularly in regards to increasing your cerebral perfusion pressure. That might be a good thing. Increasing coronary perfusion pressure. Now, coronary perfusion pressure is diastolic blood pressure minus central venous pressure. There is quite a bit of good evidence that you are much more likely to get ROSC if you have a higher coronary perfusion pressure. And the first study on this was ages ago in 1990 from Paratus, and that is a pretty impressive graph. And we do know that adrenaline, through its alpha effects, can increase the diastolic blood pressure. Now that should make some sense. What doesn't make sense necessarily is giving adrenaline in bolus doses to achieve this, and there's certainly some recent authors who have suggested adrenaline infusion instead of bolus in cardiac arrest. Now, why might adrenaline be bad? Well, firstly, beta sympathetic stimulation makes your heart work harder and the myocardial oxygen demand is going to go up, and in a state of arrest and shock where perfusion is extremely limited, that's obviously going to be a bad thing. It also decreases epicardial perfusion. It also promotes clotting, and in the post-arrest situation, you're going to decrease the microperfusion to areas of the brain that are already ischemic. We know that's a bad thing. So during the arrest and post-arrest, there's these beta problems. But the area that I'm most interested in, and this comes from the reading I've done from electrical storm, is that in the situation of recurrent or continued VFVT, adrenaline's strong beta sympathetic activity is promoting the pathway for the arrhythmia in the first place. If you haven't seen the electrical storm talk, a lot of VF and VT in fact almost all of it, is promoted by these early or delayed after depolarizations. In the delayed ones, which are by far most common, beta stimulation potentiates calcium-dependent protein kinase 2. Now, that's via cyclic AMP and release of calcium from the sarcoplasmic reticulum, and these lead to these extra after depolarizations. It really doesn't seem to make sense that in a situation where someone is dead because they remain in VF or VT, that we continue to bolus them a massive dose of a beta stimulant. So if it's true that sympathetic stimulation promotes DADs and therefore VFVT, does sympathetic blockade help stop VFVT? The answer is yes. There's a lot of electrical storm literature which supports sympathetic ablation as a treatment, including by drugs such as esmolol or heavy sedation, such as high-dose fentanyl, or anesthetics doing a stellate ganglion blockade or even a surgical sympathectomy in order to try and stop electrical storm. So in the electrophysiology world, this is a known treatment. It would therefore make sense to trial beta blockade in cardiac arrest. Has anyone done it? The answer is yes, they have. There's actually been quite a lot of animal studies around beta blockade in cardiac arrest models, and there's a review from 2016 which suggests that there is quite a lot of promising evidence, but there has been 2 recent studies of the use of esmolol. And there is one in Resuscitation 2014 by Driver et al. Now, they both use the same dose of esmolol, which is 500 mics per kilogram, it's a big dose, as a load, followed by infusion titrated between 0 to 100 mics per kilo per minute. Now, Driver had to cut out about 65 of their patients who didn't fit their entrance criteria, so he was only left with 25, unfortunately. But there is a substantial difference in ROSC in their patients, including intact survival. We'd like to see more. Lee et al., only from last year, had 41 refractory VFVT patients. Again, very similar numbers to the Driver study. Substantial difference in sustained ROSC and a doubling of good neurological outcomes at 30 days, 3 months, and at 6 months. So, although these are small studies, again, for refractory VFVT, it makes sense that esmolol should work, and early data suggests that it does. In summary, therefore, adrenaline still makes sense in a PA or asystolic arrest, and probably in the circulatory phase or the first 10 minutes of all cardiac arrests due to the increase in coronary and possibly cerebral perfusion pressure that it can cause via increasing diastolic pressure. In refractory VF or VT, to my mind, high-dose continued bolus beta sympathetic stimulation makes no electrophysiological sense at all. There are limited human and lots of animal studies which support sympathetic blockade for refractory VF and VT, and early data supports esmolol in refractory VF and VT arrest. So what's my suggestion for a new paradigm for the use of adrenaline in cardiac arrest? Now, I know there's no high-quality RCTs to support this, but remember, we've been using adrenaline for 50 years without that standard of evidence. If the patient is dead because of resistant VF and VT, they will remain dead unless you can get them out of it. So my suggested approach in a prolonged VF-VT arrest is, for the first 10 minutes, of course, do your shocks and do your compressions as well as you possibly can. In fact, you should use a point-of-care ultrasound to reposition hands to optimize left ventricular compression and be sure that you're not actually compressing the aorta or the outflow tract instead. Consider sticking in a femoral artery line and then using adrenaline infusion instead of boluses to aim for a diastolic blood pressure of more than 25 millimeters of mercury, which should give you a coronary perfusion pressure more than 20, increasing your chance of ROSC. After 10 minutes, if the VF or VT is refractory, consider stopping adrenaline boluses. consider using esmolol at 500 micrograms per kilogram. You could even consider changing your adrenaline over to noradrenaline so that you still get the alpha effect to improve the diastolic, but lose the beta sympathetic stimulation. Remember that the exceptions are in a brugada arrest where sympathetic blockade can worsen things, and acquired long QT syndrome where the same applies. So, should we arrest adrenaline's use at the 10-minute mark of all refractory VF and VT? I think this is a fascinating topic. I do think it's the first time in 40 years that frontline clinicians may have an extra string to their bow to help survival in these patients. Please comment below. Be looking forward to hearing what you've got to say. I am indebted to Long and Koifman's excellent article in the Journal of Emergency Medicine, which shortcut for me a lot of the literature search for adrenaline itself. The electrical storm references can be found at the end of my electrical storm talk. Once again, thank you so much for listening or watching Time Critical Medical Education, and I really hope that I hear from you in the future or that you come back again.